Welcome to Real Talk in Medicine, a podcast production of UT Physicians. I'm your host, Shelley Vanker, and joining us today is Dr. Matthew Harting. He is a pediatric surgeon scientist here at UT Physicians. And Dr. Harting, you specialize in congenital diaphragmatic hernia, which is also known as CDH. And for the purposes of our podcast in a tight time frame, we're going to call it CDH moving forward. Thank you so much for joining us.
Thank you for having me.
Let's start with what is CDH?
Sure. So CDH is something that not very many people know about, and it's an anomaly where the diaphragm, which is the muscle that separates the chest from the abdomen and helps with breathing, doesn't form properly. And at the same time, the lungs and the heart don't exactly form properly. Further, the things that are supposed to be in the abdomen, things like the liver and the intestines, they push up into the chest and they further compromise the heart and the lungs. And so it's something that is often diagnosed before kids are born, but the ramifications really happen right after they're born. And unfortunately, 20 to 30% of kids born with this, even in this country, don't survive. And so it's a difficult disease and one that it's really been the mission of our team to try to change the outcomes, to try to improve outcomes and do a lot of work on.
I can imagine that being very emotionally difficult. Telling a family, we see this diagnosis, but already, and then having to follow that up with what the mortality rate is with that diagnosis and still in utero.
You're right. And it's even trickier than that because a lot of times the people that tell them that they have it are the ones who first identify that something may be wrong in the community. They're at their community obstetrician who maybe sees one CDH every 5 years. It's just not that common, but they see it. And they deliver the information that they're not used to delivering, and oftentimes they say that it's not survivable, or that there's not hope, or that their baby's going to be, completely abnormal. When in reality, once they get referred to us and we have the chance to really dive a little bit deeper, understand the nuances of the diagnosis, and have a discussion with them, we really want to provide a little bit more hope for them and say, hold on, this is not only survivable, but oftentimes kids go on to have a normal quality of life and can play sports and go to school and do all the things that any of us would want for our kids. So, it's very, very difficult for that. It's one of the true joys of what we get to do is to walk with families through this really challenging time where they're learning about what is this, they're afraid for what's going to happen to their kids, but yet we want to provide some hope that we can not only take care of them, but have this result in the end that's a lot more positive than what they first either hear about or maybe read about.
So you bring hope to their case and to their journey. I love that inspiring message for something that can be very scary. And I want to talk to you about how you got into this very special field.
It's interesting how life works and how unique people that you run into, certainly in the medicine world, families and patients who inspire you, and then mentors who inspire you. I was really fortunate that I went to medical school here, and one of the world experts in CDH happened to be here, and I happened to be on his service, despite the fact that I didn't even want to be on his service. And in 1 month's time, I was just amazed. You go to the bedside of these patients and they're some of the sickest, most challenging, most complex patients in the hospital. And I knew nothing about what I was looking at, but I was intrigued. And watching him work through the challenges of taking care of these really sick patients and helping families was really the first thing that inspired me to want to take on the challenge of taking care of kids who may not survive and taking care of families who are going through just as complex and challenging a situation as anyone can go through. And so Kevin Lally was one of the first people who I was exposed to and who really showed me that there's just a beautiful opportunity in the midst of this really challenging situation. And I went on through my training and saw more and more about CDH and other experts at CDH through my residency and fellowship. And in my fellowship, I was exposed to one little girl who I later realized that her grandmother went to school with my mom. Crazy world, right?
Yeah.
And my mom had sent me a little note telling me how proud she was of me. And oh, by the way, there was this, friend of hers who said there was a Dr. Harting that was taking care of her granddaughter. And long story short, I was immediately very nervous. I wanted the outcome to be amazing. But she did have a positive outcome, and I remain friends with that family today. But walking through every step and realizing that it wasn't now just a patient that I was taking care of, which is really, really special. I take every patient really, really special, but now it's just somebody that my mom knew, and there was this connection. I really felt the need to get better, and I also realized through that process that we didn't know that much about CDH, and this is in 2011 to 2013 when I was a pediatric surgery fellow. And so I just saw this great opportunity to really grow the field, to advance the field, and to try to help other families. And those were the things that really kind of led me to become passionate about this. And this really has become my life's work and the life's work of the team that I'm fortunate to work with.
That is truly a remarkable story, to know that so few diagnoses happen, and then this particular case fell into your purview right here in Houston.
Yeah, you sort of have these situations that make you feel like it was meant to be that way, and that there was a purpose to what you were going through. But it combines so many things that I love: the technical nuances of surgery, the challenges of critical care, the need for expertise in extracorporeal life support, which is kind of a heart-lung support that a lot of the sickest kids in CDH need. But all these forces kind of came together, and like I said, it takes this whole multidisciplinary team to do that. But that was the part that I loved. I needed expertise, but I needed a team with expertise, and a group of folks who were willing to face these challenges together.
While you mentioned that, let's jump into the multidisciplinary aspect of this,
Sure.
right? This isn't just you taking on a case. You have a team of experts. Why do we need multiple levels of experts, and what do they do?
Yeah, Shelley, it's a great question, and it's a really important part, I think, of a lot of medicine, right? We talked about being in the medical center. Dr. DeBakey didn't himself, have some of the advances, or Dr. Cooley didn't, change the world himself with a heart transplant. This amazing team around him, and in many ways, even though this is on a little bit of a different scale than some of those breakthroughs, that's I have the good fortune of getting all this great feedback and getting to know these families really well. But there's this an enormous team. We talked about Ashley and a lot of the nurses and the ECMO specialists and neonatologists and maternal fetal medicine doctors. See, CDH it spans this spectrum of expertise or need for expertise. It starts from before kids are born. So obstetricians and maternal fetal medicine experts have to be intimately involved. And there's really intense care right afterwards that spans from technical expertise in surgery to critical care expertise and heart-lung bypass support, things like that. But then neonatologists, pulmonologists, cardiologists, radiologists, so many people all work together to get the little things right that have to go right to have successful outcomes in CDH. And that's still just starting to scratch the surface, right? We want kids to live, but we want them to go home and have these amazing lives. And then there's all the outpatient follow-up and the entire outpatient clinic team and neurodevelopmental expertise and nutrition expertise is such a big deal in CDH. And then, now, and we'll talk about this as we kind of work through this, but now these children become adolescents and then become adults. And where do they turn for care? Because there's not adult surgeons that are comfortable with this, and there's no pediatric hospitals interested in taking care of a 32-year-old. So now where do they go? And so we tried to sort of touch on all these things, but that's what requires a team. That requires a team of experts.
And all of these subspecialists for these cases come together in the largest medical center in the world, we like to say here in Houston, right? The Texas Medical Center.
Yeah, the energy, this is fertile ground for discovery, for tackling challenges. There's a really great book about where good ideas come from. And one of the central tenets of that book is that when you're around a group of people who think differently and who have different areas of expertise, that helps you to think differently and tackle challenges in different ways. That gets a little bit at the multidisciplinary aspect of research, right? If we all think the same way, we're not being creative in the way to have engineers and to have PhDs and physician scientists all come together and think about things differently helps us to discover new things. And that's been, a hallmark of our lab and the research that we've done, but it's a hallmark of the clinical care. And again, just being in an area where there are so many different hospitals tackling the most difficult medical challenges of our time and advancing that care, you really feel like in whatever little way for your little disease, process that means so much to each one of these families and patients, that's your job. And again, like you said, being in this environment, I think makes that possible, and it inspires you when you see everyone around you doing the same thing.
When you have a challenging case, you come to the Texas Medical Center. When you have a complex, dynamic case, we like to say that's when you turn to UT Health Houston and UT Physicians.
You're right. It's so many of the collaborators, the multidisciplinary team are UT physicians who share this love, not just for taking care of patients, but for advancing the way that we think about diseases, for, really truly generating new breakthroughs, for discovery, and for tackling the real challenges of our time, and CDH is one of those.
We mentioned at the beginning of this podcast that you are a pediatric surgeon scientist, and that's really important. Speaking of the Texas Medical Center, this is where a lot of research is done. You mentioned Cooley and DeBakey. Let's talk about your research into the field of CDH.
Sure. So early in my career, we talked about why it is that we do what we do. So I had a lot of folks that inspired me to get curious about CDH. But even in undergrad, I was able to work in a lab with a PhD who inspired me to want to be an investigator. And I thought that basic science was boring and pipetting cells, and who would want to do that? But I was really inspired in working in this lab. And I wanted to continue that. I was further inspired during my medical school time by folks that were true clinical researchers as well. So there's different types of research: basic science research, translational research, and clinical research. And across that spectrum, we needed to develop a program in CDH. I was inspired by all of these things, and I felt like this was the right opportunity to do it. And so here at the Comprehensive Center for CDH Care, we developed a basic science program that is looking into the molecular mechanisms behind CDH. We talked at one point about the fact that there's not a really known specific gene or exposure or other thing that we know is the thing that causes CDH. We don't know that, but we have some ideas about pathways and other things, and we're exploring those so that we can better develop the treatments of the future. We do a lot of translational research. How do we take the basic science things that we learn and help apply them to humans? Because that's why we're here, right? We want to help change the lives of little kids and families who are dealing with CDH. And then the clinical research aspects. We here at UT, we just led a big multi-institutional collaborative effort to do a clinical trial on CDH and are just getting that off the ground. It's kind of the first of its kind. And so we want to really recognize that even amongst the clinical things that we're doing, which one of these things are better? Sometimes there's 2 or 3 approaches to something. Well, which of those is better? How can we advance the field in that way? So we're really trying to lead efforts at all levels of research and work collaboratively with so many people around the country and around the world who are just incredible investigators in CDH. When we all come together and collaborate, that makes for the breakthroughs that are going to continue to change the way we take care of these kids and families.
And a big perk of working at UT is the academic side of it, right? It's an academic institution. And so the science is ready for you. I mean,
for sure. When I was recruited here, my boss, who's still my boss, said, we want to provide every opportunity, not just for you to take care of these complex patients or to build a team that can handle these types of cases, but we want to provide an environment where you can change the course of care and change the way we think about this disease. It's amazing to be able to take care of the patient in front of you. One of the great joys of my career. Each patient, when you go out and you talk to the family after an operation, or when you spend time walking through the ups and downs of CDH care, which can occur over months sometimes in the hospital, that's an amazing feeling. But trying to change the field, trying to change the way we all think about this disease, trying to help every single neonatologist or pediatric surgeon think about this disease. Now you're expanding the scope of how you can help every family who's dealing with this disease. That's really the goal. How can we help every single CDH patient? And that opportunity was here in ways that I didn't feel like there were many other places in the world that had that opportunity. It was one of the things that really drew me to UT Health and the University of Texas.
It is a unique combination what we're able to offer here.
It is.
And I want to talk about how your research here has changed the way you're able to speak with families or walk them through the process or treat a patient from the beginning of your research with CDH to today. How much has that progressed your care?
Yeah, great question. And it's almost a little bit, hopefully I'm still young in my career. I think they consider me mid-career now.
You are, yes.
But I'm considering myself still young in my career. And I'm going to hold on to that for as long as I can. And so I've been a faculty member here for 10 years, maybe over 10 years, but I'm going to still claim 10 years. And even in that time, there are some key things that we've discovered. And again, I want to be careful. We have an amazing team here, but it's through collaborations at multiple institutions across this country and around the world that have led to some of these discoveries. Understanding how hypoxia drives some of the mechanisms in CDH, and we talk to families about that now. Understanding specific treatments, like how better to apply this heart-lung bypass called ECMO that we use. We did some work with centers around the country and around the world, and we run what's called the Congenital Diaphragmatic Hernia study group, the CDH study group, where centers collaborate together to learn things. And some of the studies that have come from that endeavor have led to evolution in the way we think about when to do surgery, how to do surgery. There was an amazing body of work that was led by a team from the University of Michigan and collaborated again with centers all around the world that used the foundation of the CDH study group, again, born out of UT Health. And they identified all of the important factors that we know prenatally that risk how kids are going to progress postnatally and even long term. And so now, not at the beginning of my career, not 10 years ago, but now I can sit in the fetal center with families and say, let me show you the best data about what your outcomes for your child are going to be based on all these things that we know long before they're born. That's all completely new information. But that's open to centers around the country and around the world. And that's our goal, is to help everyone grow together, right? Not just for one place to be the best, but for everybody to get better at this. So there's so much that's changed just in 10 years, and it makes it a really exciting field moving forward.
Mm-hmm. Oh, that's so great to hear. And now I want to jump to a new program or an add-on to your program, the expansion truly of your program here to include what we mentioned earlier, adults who don't fall under that pediatric category anymore, who age out of the pediatric system.
Sure. So a CDH program that's truly comprehensive spans from 20 weeks of gestation, right? Long before kids are born. They're like halfway through just becoming a child that's ready to be born, right? That's when CDH is often diagnosed.
Wow.
All the way through giving birth, time in the hospital, discharge to home, being a pediatric patient, an adolescent patient. So that's a full CDH program right there, taking some, child from unborn child that has a problem and the mother and the family to, child that goes through adolescence and is now ready to become an adult. That's a very comprehensive program. We started realizing, though, in this that we had adults that were 30 or 40 who were reaching out and saying, I had CDH as a child and I have an issue, and there are not adult or pediatric hospitals that will take my case or that will help me. There's something
they're not familiar with it, right?
Sure. There's something in CDH called recurrence, where you fix it and you fix the diaphragm with a patch. But then as the diaphragm grows and as the body changes, that patch can pull away, either from the chest wall where you've secured it or from the diaphragm muscle or from other things. And then that hole is back and things can creep back up into the chest. That can happen over time. And there are a number of factors that are around that. But it can even happen when you're an adult. So you had surgery at day of life 3 or 4, and now you're 35 and you realize you have a problem. And the pediatric hospitals go, gosh, we really specialize in taking care of kids, and that ends at 16 or 18. And the adult hospitals go, well, we specialize in taking care of adult problems, and this is a kid problem. So where do you go? And there's one patient that will forever be one of the drivers for me. Went to a very well-known, very highly ranked hospital, and they said, okay, we can fix this. Had a recurrence. And they got into the operation. They're in the operating room. They called in 4 different surgeons, and they ultimately had to abort the procedure. And they came out and they said to the wife, we're really sorry, we can't fix this. And what a frustrating and devastating thing to be told. I mean, these are very young, early 30s adults with their family life ahead of them and everything. They had a young child, and she remembers, she told me the story, she just was crying because she felt hopeless. Where do we go with this? Who's going to and somebody on the internet had said, this is a CDH program. Maybe you should reach out to them. Maybe they can help. I met this family. We operated on this gentleman, was able to fix the problem, and now he's hiking and he's able to carry his daughter around and do all these things that he was worried were not going to be part of his future because there wasn't a place to turn. And that, along with a few other cases, really inspired us to start an adult component of this program. It's a need. We're fortunate to work in a hospital system and here at UT Health where we embrace the continuum of care from long before kids are born through adulthood. And so I felt like, again, that we were kind of placed here to do this, and we had the unique opportunity working in children's and adult spaces where we could take on these challenges. And so it's been a lot of fun growing the adult program and enlisting adult critical care, pulmonology expertise in surgery and thoracic surgery and others to kind of work together in this collaborative program to help adults who have a myriad of challenges that come after this childhood challenge.
Yeah. I had the pleasure of meeting one of your adult patients when your program first launched, and a remarkable story. What really struck me meeting that family was not meeting the patient himself, but the mother. And this is truly a diagnosis that can impact the loved ones who are taking care of that patient at home, right? Who see the patient struggle at home in the day-to-day. That mother cried to me when she explained the euphoria of meeting you and discovering you in your program. So truly life-changing.
It's just frustrating. We have such amazing healthcare in this country, right? And the Texas Medical Center is like the pinnacle of that, sort of amazingness. But even still, there are certain diseases or situations where you don't fit into sort of the standard box. How frustrating is that?
Yeah.
Something's wrong, you don't feel right, and you just want somebody to help you. And I think that there was an entire population that's now growing because we're taking such good care of CDH kids, and so many kids are surviving that maybe wouldn't have 20 or 30 or 40 or 50 years ago. They're now surviving into adulthood. So there's going to be more and more and more of these patients coming down the pike and reaching this age where they need a team that's going to lean into this. And not only that, not just to take care of them, but to do research around it and to really, again, understand that full continuum. How do we provide care that leads to the very best quality of life? How do we do research that helps us advance the care for these pediatric patients who are becoming adults, having families of their own? I mean, that's one of the biggest things is female CDH patients that are now coming to us and saying, I'm ready to have a family. Is that safe? What are the chances my child's going to have CDH? Can my body handle a pregnancy after everything that it's been through? What are the nuances to understanding how to do that and how to do that safely? And so there are so many of these questions that we're excited about tackling. And that, again, just putting a remarkable team together has been so much fun. And it's great to see the reward, but it's also great to build the team and to work through the challenges of the things that we don't know and how can we get better at this.
Yeah. You mentioned in there, talking about the adult program, the recurrence. So let's talk a little bit about what the fix or the solution to CDH is. You mentioned the patch.
Yeah. So, it's funny. I have a patch. Okay? So isn't it amazing that this little patch, it's made out of Gore-Tex and some other material, and this is about the size of a baby diaphragm, right? We build a patch this big, and we place it in kids, and sometimes you can use their own muscle to do it. Sometimes you can close the hole with it. So there's different ways, and there's different strategies for how we do it. Sometimes we do it with an open incision, and sometimes we use these little teeny tiny incisions that are hidden in the armpit. It kind of depends on the patient. You want to pick the right operation for the right patient. But obviously,
and this is a real patch. This
is actually the kind of patch that we use in some kids. Like I say, it's made out of Gore-Tex, right? So the same thing that is this really strong material that firefighters wear, and that certainly we've all heard about. And so we build this patch specifically for kids that's made, custom to their size of diaphragm. This is about the size of a pediatric diaphragm. Even, we've joked before, how cool would it be to write an inspirational message on here for them that the family wants, like a little message before they're born. But it's neat in looking at this to think that this small little patch, it doesn't go away, it stays there, right? Or you rebuild it with muscle, and hopefully that muscle grows, but there can be a myriad of challenges around that, and then they grow to be a full-sized human.
Yeah. And that's the solution. This is the solution.
Right. It's the solution at the start.
Wow.
But then sometimes that patch can pull away from the muscle, or can pull away from the chest wall, or the muscle that you put together loosens up. So there are things that over time, if you can imagine, a baby goes from being this size to being an adult-sized human, right? And so many things change in such a dynamic way. So there are different needs that arise along the course of that, and different operations that are necessary to help babies become, successful and happy, and pediatric patients who don't have challenges, or to identify challenges before they become potentially life-threatening challenges. So there's a lot along the way, and that of course extends into adulthood. There are different things that can require new interventions, and so again, it's fun to take care of kids and adults across the spectrum of life.
Yeah. Wow. So that it just really seeing that patch, that it feels like such a simple, easy fix that then becomes a life-saving surgery. And knowing that these patients do go on to live full lives where they are thriving, they are playing sports, they're able to run. This is one of the things that Ashley Ebanks, who coordinates our program, and I talk about a lot. We're both parents. We're not parents to kids with CDH, but we're both parents. And we can understand what it would be like to be told that your unborn child has this life-threatening disease. We also understand what it's like to have a 3-year-old that's running around that all of a sudden has abdominal pain or difficulty breathing. How traumatic that would be. Our lives are busy, and now we've got to stop, go to the hospital, try to figure out what's going on. Or for many of these families, they live with the constant, I don't want to say fear, but concern that this issue that they had when they were a baby could come back or could arise. That's really the impetus for the long-term follow-up program. And what you said is so important, and I think one of the most incredible things about taking care of CDH and their families, while these kids have an amazingly complex anomaly on the inside, if you came to our CDH clinic and you saw these kids running around, it would look like every other pediatric clinic. And just like you said, they can play sports, and they can do well in school, and they can have a job, and they can have families of their own. They can do all of the things that any of us would want for our child if we can get through the very challenging early parts of life. And that's a really, really important thing. And that's the hope that we want to provide to families. Hey, this is really challenging. It's going to be difficult to walk through this. We're going to walk through it with you. You're not alone in this. You're going to have a whole team full of people that help you with everything from all the fears that you have to answering the medical questions to helping you understand it. But if we can get through that, you can have the child that you envision that's got all of your traits, all the goods and bads that I can't resect, all the bad behavior and the, missed curfews and all those other kind of things. That's going to be part of, but we want to give that to you. We want you to have the joy of being a parent to the child that you always wanted to have. That Ashley and I say, gosh, isn't it a blessing to be a parent to kids? That's what we want to give to these families. And that's possible
for the vast majority of kids with CDH.
Yeah, wow. So well said. Thank you so much, Dr. Harting. Not only are you providing hope, but the inspiration, right, is there. You are providing that. And I think that there's something to be said about having hope and having inspiration when facing a health challenge. That's a big part of the recovery, I think, right?
There's no question. Thanks so much for taking the time today to highlight this, to highlight the amazing work that happens in the medical center and here at UT Health. And you're right. That's part of this amazing opportunity that we have as caretakers, as physicians, as the entire team that gets to wrap their arms around families with a really complex and challenging thing. That's our job. And that's our charge. How can we help them have hope and deliver on that hope so that they can have the families, the life that they'd always envisioned?
Certainly. Thank you. Thank you for joining us. Thank you for tuning in and watching this episode of Real Talk in Medicine. It was a pleasure to have Dr. Harting join us today.
Thank you.